The title of the research I'm sharing is Light Chain Cardiac Amyloidosis, Cardiac Magnetic Resonance for Assessing Response to Chemotherapy. Light chain amyloidosis is a systemic disease with protein manifestations caused by the deposition of misfolded immunoglobulin light chain, produced by an abnormal clonal proliferation of bone marrow plasma cells. Cardiac involvement is the major cause of morbidity and mortality in amyloidosis, damaging the cardiac structure causing diastolic and systolic dysfunction. Survival is significantly shorter in patients with cardiac amyloidosis, averaging only 6 months in those with chronic heart failure. In order to prolong survival, treatment should be initiated as soon as possible upon diagnosis. Current therapeutic regimens are primarily plasma cell targeted, with the primary goal of achieving rapid and profound hematologic remission, and thus organ remission on top of that. However, currently, hematologic and organ response assessments are defined by serum biomarkers. The specificity is limited and affected by renal function, lack integration with the biological features of the disease, unable to directly quantify the disease burden at the myocardial level. So there is an urgent need for more optimized assessment methods. As shown in the figure, after treatment, we can observe changes in imaging parameters. Cardiac magnetic resonance is a diagnostic tool that provides precise and reproducible information about cardiac structure, function, and tissue characterization, which may assist in the monitoring of responses to chemotherapy. The purpose of the study is to evaluate the effectiveness of CMR in monitoring responses to chemotherapy among patients with ALCA. This is a prospective longitudinal observational study to observe the changes in CMR parameters of the patients that occurred after treatment. Patients were enrolled according to the criteria before treatment, and they were followed up with a review of laboratory tests and their CMR. CMR images were acquired, post-processed, and statistically analyzed as above. 111 patients were enrolled. Follow-up data was compared with the baseline data to observe the longitudinal pattern of change, and patients with different responses to treatment were compared to observe the differences in the magnitude of change. The fold plots show superior responses in red and inferior responses in blue. Following chemotherapy, there were significant increases in myocardial T2, recovery in right ventricle longitudinal strain, and decrease in right ventricle ECV. These changes were more pronounced in the superior response group. The majority of the patients achieved superior hematologic and cardiac responses. As shown in the figure, those with superior responses are shown in red, and those with inferior responses are shown in blue. Myocardial T1 values decreased by 25.6 milliseconds in patients with superior cardiac responses, and increased by 14.5 milliseconds in patients with inferior cardiac responses. ECV decreased by 2% in patients with superior cardiac responses and increased by 2% in patients with inferior cardiac responses. It can be observed that the reduction of myocardial ECV and T1 values was more significant in patients with superior cardiac responses. Cardiac amyloid deposition can regress following chemotherapy in patients with ALCA, particularly showing more prominent regression and possibly earlier in the right ventricle. T2 increased rather than decreased with treatment, which may indicate cytoprogression due to the superimposed proteasome inhibitor-related cardiotoxicity in the short term. T1 mapping has the potential as a useful additional measure to detect a response to therapy in terms of amyloid burden, showing important implications for the management of patients with ALCA. From the present study, we can conclude that CMR emerges as an effective tool for monitoring associated tissue characteristics and ventricle functional recovery in patients with ALCA undergoing chemotherapy. CMR has the potential to optimize the individualized diagnosis and treatment of patients with ALCA. And that's all. Thank you.